Hi everybody. My apologies for that little hitch at the beginning of this. Now we're going to talk tonight about the images that you'll find in Module 10A on the connective tissue diseases. Now, as I said up here, a lot of these are in fact specialist type dermatology. And what I don't want you to learn an awful lot about them, but I just want you to focus on trying to recognize them, on the features that would make you think of those conditions. And really, I want you to concentrate on discoid lupus, dermatomyositis, and scleroderma. And at the end of this whole module, I also want you to be able to investigate a case of vasculitis, know what sort of tests to order and why you're ordering them. But it's discoid lupus, dermatomyositis, and scleroderma are the three main connective tissue disorders I want you to concentrate on. So, let's have a little look at this one. Here you can see a rash that's red and scaly. So you didn't initially go to the PM's PET. You may look at that and sort of say, oh, it looks like a fungal infection. It's got a definite edge, some scale there. But he's got some other lesions here, here. He's got some more up here. Don't know if there's a bit in his ear there as well, just in the conchal bowl there. So always, never jump to conclusions. Always say to yourself, well, PM's PET, petal, the little cat, PET, psoriasis, eczema, tinea, and petal, AL, A for an annular erythema, L for lupus or lichen planus. So at least you'd be saying to yourself, well, is it lupus, is it lichen planus? It's obviously not pit rosea, pit versicolor, or any of the other pityriasis things for that matter. Solar damage, well, mycosis fungoides, unlikely with three separate areas like that, and not in sun-exposed areas either. Remember, sun helps MF. Solar damage, you might well look at that and think it's a big skin cancer, or think that it's an SCC in situ, and do your biopsy. And it's not the first case of discoid lupus that's been misdiagnosed, both clinically and for that matter histologically, as solar damage, and perhaps a well-differentiated SCC. But this is discoid lupus. If you look at the scale, sometimes you'll see a carpet tax scale. That's where little portions of the scale go down the hair follicles, because you get follicular plugging in discoid lupus. And so when you lift the scale up, you may see these little plugs of keratin going down into the follicles. But there are other types of lupus. This is another case of discoid lupus. Let's make these images a bit bigger. They're just a touch small. Here you can see there's an active one, and these are inactive ones. Now the active one is red and scaly, but again it looks a little bit like a couple of skin cancers, perhaps SCCs, perhaps BCCs. But when you see the scarring also, it should get your attention. And also these are some early lesions here and here as well. So red scaly rash, go through the mnemonic, discoid lupus. It's a scarring disorder, that's why you've got that healing there. And then discoid lupus affecting the scalp. It's again a scarring disorder, so you will lose hair follicles. You could get a bald area there. Always look in the scalp, because you've got to shut this off quickly. It's a case of some intralesional Kennicott diluted, the A10 diluted to 2.5 milligrams per mil, 1 mil of the Kennicott with 3 mils of local, and just inject a wee bit into that. Or use the Diprazone or Novazone lotions twice daily. But you want to shut this off quickly before it does any scarring. Now, that's discoid lupus. Then you've got subacute lupus. Now, in subacute lupus, it may be red and scaly, it may be red and non-scaly. That's why the L of lupus comes in as petal, and why it also comes in as see you later, L, at the Department of Veterans Affairs, EV. So the L there also stands for lupus. It can stand for lichen planus in a red non-scaly rash. It can also stand for lues, the other old name for syphilis. and it can stand for lichen sclerosus, but normally lichen sclerosus is a genital rash. So let's have a look at this one. It's red, and most of that's non-scaly, but look at the distribution. It's on the outer aspects of the arm, the outer aspects. It doesn't go much above the shirt or blouse line. It's accentuated in the V of the neck there. So, see you later at the Department of Veterans Affairs. Cellulitis urticaria L, lupus, lichen planus, Louise, lichen sclerosus. This is subacute lupus. Now, in this photosensitizing variant of lupus, where it's certainly accentuated in unexposed areas, then they're Rho antibody positive, Rho and LA antibody positive. Let's have a look at this one. Here's another example. Perhaps a little bit of scale in this one. Again, the accentuation in the V of the neck and the sun-exposed areas. And here's another variant, but look, there is scale associated with this one. So you can get a degree of scaling in subacute lupus as well. Some look a bit psoriasiform, in fact, at times. So you've just got to keep that in mind. You can also get an annular variant of subacute lupus too. So it's one of the rarer manifestations of an annular erythema is subacute lupus. Okay, so the other variant of lupus, by the way, you have is systemic lupus. Systemic lupus looks a bit like subacute, but often there's that very famous malar rash, butterfly rash on the face as well. Usually it's a generalized erythema they get. It's not just in sun-exposed areas, and they're usually systemically unwell with joint and other problems. You can get another type of lupus due to Rho antibody. Here is a child with neonatal lupus, a rash appearing in the first few weeks of life in sun-exposed areas, and it's because of Rho antibody, IgG antibodies in the mother that have crossed over in the placenta and they're in the babe's circulation. Remember I said in subacute lupus that these antibodies can sometimes damage the conducting system of the heart, and sometimes these babies are born with congenital heart block. But in the first couple of months or so they can get this rash as well in sun-exposed areas, and then it just all peters away and settles down. But it's one to think about in a child. Now you might look at that rash, let me just think. You might look at that and say, it's red, perhaps slightly scaly. Is it an eczema? Is it seborrheic dermatitis that the child's got? But I think there's a wee bit involvement even in the ears here. And it's extending up into the scalp margin. You could be forgiven for thinking that's seborrheic dermatitis, but you go looking at the other areas as well and see if there's any features of seb derm behind the ears, in the scalp if there's a fair bit of hair. This is the other type of lupus you can get, which is drug-induced lupus, and some types of subacute lupus can in fact be drug-induced. If they are drug-induced, they have antihistone antibodies and they're Rho antibody positive. So the classic thing to ask for if you're looking for drug-induced subacute lupus is to ask for antihistone antibodies. So you ask for ANA and ENAs, the extractable nuclear antigens are Rho and SSA. Okay, that's your lupus pictures. Now we go on to dermatomyositis. This one's of some importance because dermatomyositis in older people, and that means people over the age of 60 to 65, if it suddenly comes on, it can be a marker for internal malignancy. And you've got to look at lungs, breast, and stomach cancers if you're considering this, and bowel, and do the appropriate investigations to exclude those. Someone with dermatomyositis will present with periocular, what they call a heliotrope, a purplish sort of discoloration here. And often there's some edema as well. There's a bit of as well as the purpley color, there's some periocular edema as well. They usually have a degree of photosensitivity and sometimes have a rash in the elbows, the points of the elbows, where you might not expect it, and the points of the knees. This here is another manifestation of the photosensitivity. Look how they're sparing underneath the chin there in the bits where the sun doesn't reach. Look at the degree of edema that he's in fact got in his face there, that periocular edema. And this area here has got a fairly extensive rash too. It's usually non-scaly as well. And then I've made a little comment here about the rash over the dorsal elbows and knees. But this is the other area you go looking for with dermatomyositis. You go looking down at the fingers. And they usually have some periungual erythema and perhaps a very ragged cuticle, as in these cases. Look at the ragged cuticles here. And this one isn't so bad. And the periungual erythema that they get. They'll also often get some redness over these joints as well. And they may get some lesions called Gottron's papules. I think you'll come across these in another thing I'm going to show you. But Gottron's papules are flat wart-like things that are over the surface of the knuckles. The intervening bit of skin here between the joints is usually okay. So the erythema is here and on the knuckles themselves, with clearing in between in dermatomyositis. Whereas in lupus, in subacute lupus or lupus or systemic lupus, this is the bit where you get the erythema, in between the joints. That's where the skin will get red. They may get a wee bit of periungual erythema as well, but the erythema is going to be in here, whereas that's spared in dermatomyositis. So it's a very useful little clinical feature that in separating dermatomyositis from systemic lupus. Remember, dermatomyositis can be part of mixed connective tissue disease. They can have some little features of lupus, little features of dermatomyositis, and sometimes even scleroderma-like features, which makes life difficult. The next condition you have to look at is scleroderma, sclerosis in the dermis. Thick collagen laid down. The skin becomes hard or rock hard. When you try and grasp it in between your fingers, it won't come up as a fold. It's all bound down. And often there's a degree of either hypopigmentation or even a wee bit of hyperpigmentation. Let me show you. This is the abnormal skin here. So is all of this. You see that background of almost what they call salt and pepper pigmentation. Hypo and little hyper bits of pigmentation there. That's salt and pepper pigmentation. You see that in skin, and if it feels very firm to the touch, then the patient's got scleroderma. Depending on the degree of sclerosis, you'll sometimes get some white areas like that as well, if there's quite marked sclerosis. The other name that's given to this is morphea. But usually morphea is just a few localized patches rather than a whole generalized area of skin thickening, which is what we've got here in systemic sclerosis. There's a better example of that salt and pepper pigmentation that you'll in fact see in the involved skin in someone with scleroderma. And this is the other feature you'll see in a lot of cases of scleroderma. If you look at the fingers, they're flexed like that, and they're bound down. The skin's tightly bound down. You get sausage-shaped fingers. And you also may get a little bit of perforation here with a bit of calcification. You can sometimes get calcification in the skin here, and the body tries to expel a bit of calcium through the skin, so you get a bit of perforation with calcium trying to come out. So tightly bound down fingers, sclerodactyly, is a classic feature of scleroderma. There are certain types of scleroderma, and the one that you're most likely to see is a thing called the crest syndrome. And that crest is an acronym, C-R-E-S-T. The C stands for calcification in the skin. The R is for Raynaud's phenomenon. They get that alternating white and purple fingers in cold weather. CRE is for esophageal dysmotility. They have some difficulty swallowing because the process can involve the esophagus and narrow it. The S is for the sclerodactyly, and the T is for telangiectasia on the face. They get a special type of telangiectasia called matte telangiectasia, M-A-T, I think there's 2 T's, matte telangiectasia. And you'll see a picture of that, I think, in another part of this module. So the crest syndrome. They're usually speckled antibody positive as well, ANA positive speckled antibody with I think it's an anti-centromere pattern that they in fact show in their antibody pattern. When you look at it, it's not homogeneous. Now, this is localized scleroderma that I was talking about before, morphea. There's various types of this as well. There is just a solitary plaque there. Notice how it's slightly white, and it'll feel very firm. There may be a slight purple edge to it as well. In fact, the very earliest form of morphea in the skin will be purplish, and it will feel slightly firm. And then, as you get more sclerosis occurring, it's really all white, just with a wee bit of purple maybe around the outside. This, I think, is a close-up of that particular image. Must be a fairly big file. It's taking a little while to load. There we go. Yeah. Now, that's it there. You get that fine wrinkling of the skin as well. It's like a cigarette paper wrinkling, but it won't wrinkle up in your fingers. It's firm underneath. And this, as I say, this whitish color is due to the excess collagen laid down. The thing that I've said there, note the slight surrounding violaceous color of the active edge of this. Difficult condition to treat morphea. Strong topical steroids can be used there locally to try and suppress the process. We don't know the cause. Some parts of the world, in Germany, it's actually a Borrelia infection. They get Borrelia injected into the area from a tick bite, and then they seem to get localized areas of morphea occurring at these areas. Here in Australia, we've looked for this. We haven't seen any evidence of it at all. In places like Germany, allegedly they give penicillin to hit the Borrelia, and they can sometimes cause morphea to stop and do involute. We haven't had the same success here in Australia, so there must be some other cause that's responsible here. There's a variant of morphea that's a linear variant. You can see it here running down across this joint. If you feel that, that's quite firm. You can see the little purplish edge to that and the white sclerosis in the middle. The problem with that band running across there is that it can impair proper straightening out of the knee joint there, and they can get a flexion deformity. And if ever you get a child with linear scleroderma like that, you've got to send them to a physio to work on this to make sure they don't get sclerosis there. Oral steroids will sometimes help with this condition, but it's difficult. Sometimes a little injection of intralesional steroid, Kenacort, at these edges will help the condition as well. Divanex has been used. Don't know why it works. And the other thing that may be used is tacrolimus, which is an anti-T cell topical. We don't have it really here in Australia yet. Elidel is the one we have, but it just won't penetrate. But tacrolimus, the 0.1%, can be made up ointment, and it can sometimes help this condition, but this is a difficult condition. Usually it progresses for a while, burns out, and then settles. By the way, when localized morphea here burns out, often it will leave a bit of post-inflammatory hyperpigmentation there, because the sclerosis just softens, but it leaves some hyperpigmentation on the surface. So these are unusual conditions. I've tried to just indicate the main clinical features here for you. Know the features of the crest syndrome and scleroderma. Know dermatomyositis and the areas that are involved, and especially the fingers. And lupus. Know a little bit about the antibodies, which ones are positive in subacute as against discoid. Immunofluorescence biopsies are much more likely to be positive in subacute and systemic than they are in discoid lupus. And know that discoid lupus can be mistaken for solar damage, and always consider it as part of your mnemonic. And remember, it's a scarring disease, and if it affects the scalp, it can cause baldness, and obviously here it can cause significant scarring and damage to melanocytes and white areas as well. Look at Habib's section on this. Just look at the images. Don't waste time reading too much about all the details. I just want you to get a feel for what the images look like, what mnemonic to use, and to learn to bring it into your differential diagnosis of red scaly and red non-scaly diseases. Thank you very much.